Claro, remarked Ursina. Here are USMLE-style questions focused on hypoaldosteronism or aldosterone resistance, as seen in type 4 renal tubular acidosis, characterized by hyperkalemia, decreased ammonium NHS excretion, and non-anion gap metabolic acidosis. Question 1. Hyperkalemia and acidosis. A 58-year-old man with a history of diabetes and chronic kidney disease presents with fatigue and muscle weakness. Labs reveal K-cut 5.9 mg/ml, HCO₃, 17 mmPa, Na 140 minute, urine pH 5 anion gap normal. Which of the following best explains the acidosis? A. Inability to reabsorb bicarbonate in the proximal tubule. B. Failure of α-intercalated cells to secrete HCO₃. C. Decreased NH3 synthesis due to hyperkalemia. D. Excess aldosterone activity in the collecting duct. Answer C. Decreased NH3 synthesis due to hyperkalemia. Explanation: in type 4 RTA, hyperkalemia suppresses ammoniagenesis in the proximal tubule, NH- excretion, H- excretion, non-anion gap acidosis. Question 2. Underlying mechanism. A patient with poorly controlled type 2 diabetes develops persistent hyperkalemia and metabolic acidosis. Aldosterone levels are low. What mechanism contributes to his acid-base disorder? A. Excess renal bicarbonate loss. B. Impaired hydrogen ion buffering. C. Decreased NH- excretion due to impaired NH3 production. D. Increased distal tubular acid secretion. Answer C. Decreased NH- excretion due to impaired NH3 production. Explanation: hyperkalemia reduces proximal tubular NH3 synthesis, leading to decreased NH- excretion, which contributes to acidosis in type 4 RTA. Question 3. Drug-induced type 4 RTA. Which of the following medications is most likely to cause type 4 renal tubular acidosis? A. Thiazide diuretics. B. Furosemide. C. Spironolactone. D. Acetazolamide. Answer C. Spironolactone. Explanation: spironolactone blocks aldosterone receptors, decreased NMPI reabsorption, and impaired Kase and H-by excretion, hyperkalemic acidosis. Question 4. Aldosterone resistance. A 55-year-old male with longstanding diabetes has Kase of 6.22 mmHg and HCO₃ of 18 mmHg. Aldosterone is normal, but renin is suppressed. What is the most likely cause of his acidosis? A. Primary hypoaldosteronism, renovascular disease. C. Aldosterone receptor resistance. D. Loop diuretic use. Answer C. Aldosterone receptor resistance. Explanation: normal aldosterone but ineffective response, common in diabetic nephropathy, causes aldosterone resistance seen in type 4 RTA. Question 5. Which of the following laboratory profiles is most consistent with type 4 renal tubular acidosis? Electrolyte value: K, HCO₃-, urine pH 5.5 anion gap normal. A. Type 1 RTA. B. Type 2 RTA. C. Type 4 RTA. D. Diabetic ketoacidosis. Answer C. Type 4 RChin. Type 4 RTA is unique among the RTAs in presenting with hyperkalemia and a low urine pH, despite metabolic acidosis. Summary tip for your notes: TA type defect, urine pH, because among the RTAs, a pH. Type 1, α-intercalated cells, H- secretion. 5.5, Sjogren, autoimmune. Type 2 PCT HCO₃ reabsorption, variable. Type 4 aldosterone resistance. 5.5, diabetes, ASI, spironolactone. Would you like a printable flashcard deck or compare